Moving to the next section, that is evidence-based approach to amblyopia treatment by Dr. Revathy Mani, who is our international speaker of today's conference from Australia.
But ma'am is not able to join us due to unavoidable circumstances.
But due to our persistent request, she agreed to join us online.
We all request your cooperation and support and kindly bear the inconvenience.
Now, I request Ms. Rahana, student representative, to introduce our international guest speaker.
I am very delighted to be here to welcome our next speaker, Dr. Revathy Mani. She received her bachelor's in optometry and MPhil degree in optometry from Elite School of Optometry affiliated to Birla Institute of Technology and Science. In 2002, she joined Shankara Nethralaya as an optometrist. She was the head of Department of Binocular Vision and Vision Therapy. She is a fellow of the Neuro-Optometric Rehabilitation Association in USA. Also, she is the recipient of the 2019 William C. Easel Fellowship Award from American Academy of Optometric Foundation. She had completed her PhD from School of Optometry and Vision Science, Sydney. So, now I request ma'am to forward the speech.
Okay, thank you very much. First of all, I want to thank the Mangala Institute of Allied Health and Mr. Jayakumar and Mr. Thamizhalan for inviting me for this talk and on this celebrating the World Optometry Day. So my topic is about evidence-based approach to amblyopia treatment. I am a lecturer and researcher at the School of Optometry and Vision Science. So, okay. Okay, so I'll just give a brief introduction about myself. So I finished my bachelor's and master's from Elite School of Optometry from in India, and then I was working as a optometrist and lecturer at the Elite School and also at Shankara Nethralaya. I was also working in the binocular vision and vision therapy amblyopia clinic. Later, I established the Neuro-Optometry Clinic after I finished the fellowship from Neuro-Optometric Association from the US. And then I joined the PhD to explore the abnormal eye movements in traumatic brain injury. And I finished my PhD in early 2021 at UNSW Sydney, where I work as a lecturer and researcher. So the experience that I've got from the binocular vision clinic and the amblyopia clinic from SN is what I'm going to share today. Though my research was all about abnormal eye movements, but I want to just talk about some research, evidence-based practice in amblyopia. So today my talk will cover all these points, like I'll begin with the definition of amblyopia, the symptoms, and I'll focus more on the current treatment that has got a more evidence-based practice, and then a little bit about emerging trends and what are the future scope in the treatment of amblyopia. So to begin with, so what is amblyopia? It is defined as a decreased in vision in the best corrected visual acuity in one eye or both eyes. Mostly it is in a single eye, but sometimes it could be also in both eyes, where there is no structural evidence of abnormalities or any ocular diseases. So there is no ocular disease or structural abnormality, but you still see some decrease in the visual acuity, which cannot be improved using glasses. So it usually occurs in infancy or early childhood, and the prevalence is around 1.5 to 3% worldwide. So it basically interrupts the cortical visual pathway in the ocular development. So the earlier the treatment, the better the prognosis. And there is always a difference in the visual acuity, at least 2 lines between both the eyes. So the etiology of amblyopia are, these are the basic types. So it could be refractive or anisometropic. Usually it is maybe hyperopic or myopic. or astigmatic. But it can also be caused by strabismic, where there is ocular deviation, and the deviated eye being experiencing decreased vision, and mostly it is because of esotropia. And there are also combined mechanism where you get refractive and strabismic amblyopia together. The last one is the form deprivation amblyopia, which is because of congenital cataractosis and any other media opacity that can impair light stimulation in the retina. So the first three can be treated by glasses or patching or atropine, but the last one needs surgical intervention due to the reason that is caused for the form deprivation amblyopia. So what are the symptoms? The patient usually has decreased vision in one eye. There may be poor contrast sensitivity, poor depth perception, and if there is any associated ocular deviation, there can be suppression of that eye. And there are also poor accommodation, which affects their near vision, and poor eye-hand coordination. And this affects the quality of life, because if the amblyopic patient wears glasses with a patching, so there can be bullying in the school, or they have actually a lot of problems in the school, and also in social activities. They can't engage in sports. So there are a lot of problems that they face during this kind of issues. And when they become adult, when they don't get proper treatment, they have problems in driving, and also securing some job opportunities like medicine or aviation or any other job opportunities that require intact vision, including stereo acuity. So basically, if it is untreated, it can actually affect the mental health of patients. So I'm not going to go into the details of ocular examination, but these are the few highlighted points that I wanted to stress. So always check acuity, which has got the crowding lines, so that you can rule out crowding phenomena, and also test for stereo acuity, and by that all the tests that test the binocular functions like RAN dot, specifically the RAN dot stereo acuity chart and the Worth 4 dot test, and also ocular motility to rule out any strabismus. And we do the normal anterior segment and posterior segment, but more emphasis on cycloplegic retinoscopy, because we are going to prescribe glasses. So any amblyopic patient, when it comes to your clinic, kindly do the cycloplegic retinoscopy, and based on that, we prescribe the glasses. And there was a recent paper on the quality of life of amblyopic patients. So this is a very interesting paper that I thought I can share it. So it basically affects all facets of an amblyopic patient, right from their family, their social interactions, and the activities that they do in a daily life, and how they feel and behave when they have amblyopia. So it actually affects their mental health very, very much. So it's better to have them early treated, detected and early treated, because it also affects their family, like the parents, like seeking treatment and following up, and also the patient experiencing social isolation because of the fact that they wear very high power glasses or patching glasses, and also the inability of them to participate in the sports, or even it can affect the education because of the decreased vision for distance. And so overall it kind of disturbs their self-esteem, and which leads to depression and frustrations, because they can't be like a normal kid who has got intact vision. So I'm going to just describe about few of the treatments that has got evidence-based approach, which has been recently very well investigated by the pediatric eye disease investigator group. So the primary treatment of amblyopia is all these which I have listed here: the optical correction of refractive error, patching, and atropine penalization. So there are a lot of research that has been recently done to understand how all these three works. But there are also a few other emerging treatments that was also investigated and also researched. So I will little bit sum up that in the end. So the treatment of amblyopia actually depends on all these listed things that I have listed here. So it depends on the critical period. So the critical period is around 6 to 8 years of age. So the early the better, the diagnosis and the treatment. So So any patient for that matter, if you diagnose with amblyopia, we have to start the treatment as early as possible because the prognosis is much better. And when do we start the treatment? It also depends on the initial visual acuity. The milder the amblyopia, it's easy to treat rather than the severe one. Even a severe amblyopia can be. We have to start the treatment as early as possible. That's what I want to mean. And then the etiology. So if it is an anisometropic amblyopia, or is it a strabismic amblyopia, or is it form deprived amblyopia? So you have to basically understand what is the etiology, and accordingly we have to start treating. And severity, whether it is moderate or mild or severe, and also the commencement of the therapy. So when do you commence? Like after 1 year of diagnosis, or immediately as soon as you diagnosed the amblyopia, and also the duration of therapy. So you cannot do a therapy like just 1 or 2 months or 3 months and then stop, because especially for severe amblyopia, you need to do maybe 2 years or 3 years with a regular follow-up. And then the speed at which tapering the treatment. So when you see that there is an improvement in the visual acuity, you should not stop it abruptly, because that can also affect the amblyopia, and then it can go to reverse amblyopia, or there could be recurrence. And the compliance and motivation towards the amblyopia treatment is very, very important. That's what I feel from my clinical experience at Shankar Nethralaya. So whatever it is, if it is a severe amblyopia or a mild or a moderate amblyopia, if the patient is able to continue the patching or whatever treatment that we give very regularly as advised, then that is the best option for them to get rid of amblyopia as quickly as possible. So the motivation from the parent point of view and the compliance together with the cooperation of the patient and the parent is very, very important for very good prognosis. And from the optometrist and the ophthalmologist point of view, we have to follow them up very, very regularly, at least once in 3 months, so that we don't miss the recurrence of amblyopia or the residual amblyopia. So I want to just give you a classification of amblyopia as mild, moderate, and severe. So these are the classifications, because I'm going to just talk about the moderate and the severe amblyopia in this talk often than the mild. And we also need to know the amblyogenic factors of this amblyopia with respect to refractive error. So any patient, you have to compare that with their emmetropization process. However, if they have hyperopia, myopia, astigmatism of this given degree of refractive error, it could be amblyopia-genic, and then you have to start treatment as early as possible. So this PEDIG, as it is called, this is Pediatric Eye Disease Investigator Group. So they have done extensive research on amblyopia treatment therapies for severe, moderate, and then for strabismic, refractive, and combined mechanism. So I've given you the link there, and if you are interested, you can just click the link and then study more about it. But I'm going to summarize few studies from them today. They have done very extensive, so many number of publications, but I cannot, describe everything in this half an hour lecture, but I'll try. I have tried most important ones in this lecture. So I'm going to just cover these aspects in this lecture. So what they have done for refractive strabismic and combined mechanism, and for moderate and severe, and what is the patching regimen that they have advised, and also atropine penalization procedures, and whether it improves with near activities, and how would the recurrence of amblyopia. Why PEDIC studies are very important is because most of the studies were randomized to clinical trial or prospective observational study without any bias, and they're all masked studies. And also they have dealt with all types of amblyopia which we see in our day-to-day life, and they're all multi-centered, so we can see all types of amblyopia that has been dealt in this series of studies. And they have got strict criteria, they have followed up very well, and they have stuck to the cycloplegic refraction and with all the logMAR charts, unlike the Snellen charts. So these are like standard vision charts that they can be very reliable in their measurement of visual acuity. And all the studies had visual acuity as the outcome measures. So we are going to focus only on the visual acuity improvement, though there are other aspects of vision that is affected. So the first thing is The first thing is all about the optical correction. So the first line of treatment for any amblyopia, previously what has been considered was patching. But before that, optical correction is the first line of treatment. That's what all these studies, which I have noted down, says. So they took a group of 146 kids who are aged 3 to less than 7 years. So they are preschoolers. So they took all the strabismic, refractive, and combined mechanism. And they took the moderate and the severe amblyopia with a visual acuity of 6/12 to 6/60. And who never received any treatment. So the first thing that they did is they gave glasses and saw what happens to them, what happens to the visual acuity. For the refractive amblyopia, where there is only refractive error, they followed for 5 weeks. However, for strabismic and the combined mechanism, they followed every 9 weeks and 9 and 18th week. So let's see what are the results. Okay. So here is a table. I have just summarized 2 studies and I have just added the results here. So here, the first, under the refractive amblyopia, there were 3 lines of improvement just wearing the glasses. And for the combined and the strabismus also, there were 3 or equivalent to 3 lines of improvement. And there is a significant percentage of patients who showed actually pretty much improvement in the visual acuity just by wearing their optical correction. So if a patient comes to you with a amblyopia, you don't have to directly give them patching, because number one, the kid is like very much new to the wearing refractive error, and so if you give refractive error and patching together, there'll be the patient may not be comfortable in doing so. So all that we want to do is just give them optical correction at least for 4 weeks, and so that they get adapted for the refraction, and that itself provides you a good improvement in the visual acuity of about 3 lines. That's what these 2 studies summarized. And when there is also bilateral refractive error, they were also able to investigate like around 113 kids who were aged less than 10 years who had bilateral refractive amblyopia. So here again, they actually followed this group of children for around nearly 1 year, and they found that there was increment in the visual acuity of 3.4 lines in moderate visual acuity, moderate amblyopia, and 6.3 in severe amblyopia. So basically what they wanted to convey that first line of treatment is optical correction, and then you think about other modes of treatment. And there was a recent meta-analysis that also kind of said the same story. So they gathered all the articles that gave optical correction. So these are the articles, it's listed here, and this is a forest plot that describes the effect size. So the y-axis is the number of studies, the studies that they have done, and the x-axis shows the effect size. So if the effect size is 0, means there is no improvement in the visual acuity with the optical correction. But here you can see that there are significant increase in the effect size. As you see, there are many studies that showed values beyond 0, which means that there is an increase in the visual acuity after giving just the optical correction. So usually the meta-analysis and systematic review just summarizes the results that has been gathered from all the original studies and gives you a nutshell of what results that they have got. So the effect size was around 1, which means that there is significant increase in the visual acuity just by giving the optical correction. That's what this says. And there is another interesting result that they have showed that it is the graph on the left shows the effect size with respect to the age. So the earlier you treat the amblyopia, the better is the effect size. As you can see, the age around 4, the effect size is around 1.5, and as the age increases, the effect size decreases. So it's better to start the treatment as early as possible. And also, if you give the treatment for a longer time, the duration, the effect size also increases, which means that you have to kind of continue the treatment until you reach the visual acuity equivalent to the other fixating eye. So the summary of these studies is that optical correction is a first line of treatment for amblyopia, and it works not only for the anisometropic or refractive amblyopia, it also works for strabismic and combined mechanism amblyopia. So the next line of treatment, which is very, very common and kind of gold standard, is the patching. So patching is very popular for amblyopia. So anybody who knows about amblyopia must know about patching. So they also have done few research on the patching regimen. So when you advise patching for an amblyopic patient, how many hours should you patch? So we actually say them to patch full time, right? But they also have compared some number of hours. So they took few moderate amblyopia and few severe amblyopia, and for moderate amblyopia they compared between 2 hours versus 6 hours. And for severe amblyopia, there was a comparison between full time versus 6 hours, and these are the specification of their methods. So what they initially did is gave them glasses for 4 weeks, adapted them for whatever refraction that they have got binocularly, and then after 4 weeks they gave them patching. And they compared for moderate how is a visual acuity improvement for 2 hours versus 6 hours, and for severe full time versus 6 hours. Let's see what is the result that they have got. So for moderate amblyopia, they got equal number of improvement in the lines for 2 hours and 6 hours. And for severe amblyopia, the improvement was similar between full time and 6 hours. So this says that you don't have to, for moderate amblyopia, advise 6 hours, because even for 2 hours, it gives the equivalent improvement. So if you have a patient who have got moderate amblyopia, you start with the refractive correction in the initial 4 weeks, and then start at least 2 hours of amblyopia, because they'll be a little bit compliant for your patching rather than doing 6 continuous hours. And similarly for severe amblyopia who have got very, very decreased vision, like worse than 6/60, you start with the patching after one month of refractive adaptation with just 6 hours, not the full time. So this actually improves the compliance of the patient towards patching regimen, which will give you very good results. As you can see, there were like 5 lines of 4.5 to 5 lines of improvement in severe amblyopia also. However, patching is not a good thing for kids, because they may not like it. So since there is a poor vision in the amblyopia eye, and also it is very uncomfortable to wear, and there is a lot of social problems, acceptance among the their peer groups when they do sports or when they are even in a class. So it basically affects the quality of life, and there is also decreased binocularity, and sometimes there is no motivation. So if you have come across any of these ones, what alternative treatment instead of patching is the Bangeter filters. So what are Bangeter filters? They are very thin polyvinyl. They are very thin layer, which is translucent in nature, which can just be stuck. And depending on the visual acuity, you can choose the number of Bangeter filter. So this is applicable for people, complain with atropine or patching. This could be used instead of patching. And there is one study here which I'm going to show. So they have compared full-time wear of Bangeter foil, and they compared with hours of daily patching. So they compared full-time wearing Bangeter with 2 hours of daily patching, and they still saw some increment in the vision of 2 lines when they wore the Bangeter filter compared to kids who did 2 hours of daily patching. So this is an alternate treatment instead of patching for kids who are very poorly compliant with patching. There are a little bit of advantage and disadvantages with the Bangeter foil. The Bangeter density. So what are the advantages? It's just a single layer that you can just stuck it on the glasses. It is cosmetically appealing. Nobody will know that the patient is wearing a patch, and little bit of binocularity is restored. What are the disadvantage of this is there is always the kids always peek outside the glasses because it's just stuck on the glass instead of, unlike the patching regimen. And it also degrades over a period of time. So you have to replace the bang-eater foil after maybe 2 or 3 months, depending on the, the dust that gets accumulated on the glasses. So the next line of treatment is atropine penalization, which is the next treatment that is adopted for amblyopia next to patching. So what is atropine does is, the atropine is instilled not in the amblyopic eye, but fixating eye. So what does atropine does is, it dilates the pupil, it arrests the accommodation so that the near vision is affected and they have only good vision for distance. So it is basically instilled in the good fixating eye, the sound eye, not in the amblyopic eye. Because this education is very important to the parent, because they always think that the affected eye is the amblyopic eye and you are asking them to put the drops in the good eye. So always explain this to the patient, that patient's parents, that the atropine is for the good eye, not for the amblyopic eye. So they compared, the PEDI group also compared how is the efficacy of atropine and patching, like which one is better. So they took like around 419 kids who were like aged between 3 to less than 7. They took all the strabismic, refractive, and combined mechanism amblyopia with the specification as I listed. They compared the patch versus atropine, and they followed up every 5 weeks, 16 week, and 6 months between these two group of treatments. So as you can see here, there is a graph which shows on the y-axis the mean change in the visual acuity, and the x-axis shows the treatment groups between patching and atropine for 5 weeks, 16 weeks, and 6 months. You can see at 5 weeks, the patching group actually showed very good improvement compared to the atropine, but gradually at 6 months, both the groups gave more or less the same kind of improvement in the visual acuity. So of around 3 lines. So this says that patching and atropine can be interchangeably given. So those patients who are very poorly compliant with can actually provide atropine. And atropine is very, very easy to do, because you just need to put the drops in the eye when the patient sleeps or so, and it's very easy for parents to do this one. And it is it's so easier to administer, and it is of lower cost, and it also has got long-standing effects. And what the studies have found out, this study particularly has found out that there is no significant side effect that has been reported. So it is kind of safe to use this eye drop of atropine of 1%. So they concluded that atropine and patching produced improvement of similar magnitude, and both are appropriate modality for initial treatment of moderate amblyopia for this age group, which is 3 to less than 7 years. So this is a good news that atropine and patching could be interchangeably used. Now, so if you use atropine for amblyopia, how should you use? So there was another study which was designed whether you have to use atropine on daily basis or it should be used on weekly basis, because it has got some side effects. So this study was designed based in order to explore whether it should be used daily or in a weekly basis. So atropine 1% was chosen, and the patient was given optical correction for 1 month. And so what basically atropine does, as I discussed earlier, so it makes the good eye, it gives blurry vision in the good fixating eye, and so that the amblyopic eye could be forced to see the near vision and also for distance. And since we are not sure whether to use it daily or weekend, so they compared daily versus weekend drops and compared the visual acuity, what happened after that. So this is a graph that explains the mean change in the visual acuity for daily and weekend group. So you can see that the visual acuity actually improved in a similar way for daily and weekend atropine compared to baseline at 5 weeks and after 4 months. And they also found that 80% of the patients reached the maximum visual acuity by 4 months. And 50% of the recruited patients actually improved better than 6 by 7.5. So this study actually concluded that weekend atropine provides an improvement similar to that of daily atropine for this group of kids. So it is better to use it in the weekend rather than daily. And it gives a similar kind of improvement like patching. So it is more safe to use in kids. And also they included few more kids who were aged 7 to 12 years and wanted to test whether it is working for them also. And they compared atropine 1% with patching, and they also found similar improvement. Though patching was always a little bit more than the atropine, but they had kind of just one line differences after 17 week of assessment. So they said they again concluded that patching and atropine can be interchangeably used even for older kids who are 7 to 12 years old. So the summary of this thing is like this particular treatment trials where the weekend atropine provides similar magnitude in improvement in VA like the daily atropine, and it can be used for both moderate and severe amblyopia and for younger and older children. And the next set of study that they did in older children was that since the child is actually older and a little bit matured enough to understand what treatment that we are giving, so they compared two types of treatment. One, only the optical correction or the atropine with some kind of patching and near vision activities. They want to see whether additional near vision activities of 1 hour could improve the vision or not, instead of not giving any activities and just giving the optical correction. So they did this in group of children who were aged 7 to 17 years old, actually. So even more older children who had residual amblyopia. So they gave 1 hour of near activity, like they asked them to play some games or computer work or even doing homeworks for 1 hour, along with 2 to 6 hours of patching. So they compared the group which had only optical correction with another group which had all the three combinations of treatment. So this is the result that they got. So so there was only 25% increase in the visual acuity for kids who were 7 to 12 for the optical correction alone, while in the active treatment there were 50% increase in the visual acuity. And also the children who were 13 to 17 who had no refractive error treatment at all in their life previously, they actually showed more improvement. So when they did this combination of treatment, so even if a child comes to you like around 13 or 14 or even 15 years old, there is no harm in starting the correction with the patching along with some near vision activities that has been mentioned in this paper. So it's always better to start treatment whenever you find the amblyopia without stopping the treatment or not giving them good hope. So there is always some kind of improvement that could be seen according to this particular study. So yeah, always older children, they respond, but optical correction actually improves in 1/4 of the patient if they are older, like 7 to 17 years. For 7 to 12 years, 2 to 6 hours of patching plus near vision activities actually works. For 13 to 17, who are older children, even there is no treatment, patching 2 to 6 hours per day plus near vision activities actually improves their visual acuity. So there is always residual amblyopia. So we have tried the optical correction, patching, and atropine penalization, everything. And we wait for like 3 months to 4 months and see whether the visual acuity improves. But visual acuity stops improving after a while. So we can't reach the maximum visual acuity of 6/9 or 6/12 for a few patients, right? So this is called residual amblyopia. So whenever there is a residual amblyopia, after you have tried the normal, the treatment that I have discussed now, you have to just go back and check a few things that I'm going to discuss now. So just go and look at the compliance of the treatment, whether they are following the atropine treatment or not, whether they are following the even the optical correction, whether the kid is wearing the optical the refractive correction or not, the glasses. So you can actually go and check whether there is regular use of glasses, especially when they go to school. We have to actually educate the teachers and the parents that the regular use of glass is actually going to work. So the compliance of the treatment should be followed. And even we can recheck the cycloplegic refraction again to see if there is any kind of variation in the refractive error. So these are the two main things that we can do. Suppose if you have fixed all this, so the compliance is good, you have the refractive, the cycloplegic refraction is checked, and all the glass power is good. If the patient is not responding to 2 hours, you can actually increase the patching to until 6 hours, and then you can follow up them every 3 to 4 months until the visual acuity improves. Then if you give an atropine treatment, what you can do is you can add a plano in the good eye, the sound eye. Maybe because that, since you have given the optical correction for the good eye, which is, say, for example, it is hyperopic or myopic, you have given the optical correction. Maybe the patient is not using the amblyopic eye, though atropine is working. So you can actually give a plano correction in the sound eye, which has got some refractive error, and so that the amblyopic eye could be forced to use compared to the sound eye. And you can also combine patching and atropine. So this is all is advised for residual amblyopia if you feel that the vision is moving after you have tried like all the established treatment. And later, so after you have tried all these combinations, you can actually start doing even some active vision therapy, like to train their accommodation, train the stereo acuities, train their fusional vergence amplitudes. So this actually works a little bit from my experience from the amblyopia clinic. So we usually wait the visual acuity to improve until 6/12. And once they reach 6/18 to 6/12, we actually start some accommodative therapies and fusional reserves. Though there is no very nice, RCTs that has been established on this vision therapy, but it really works for many patients. From my experience, I'm just sharing this fact. And the next thing that we have to think about is when to stop the treatment, right? So amblyopic patients come to you and you give the treatment, but always the parents ask, when should I stop the glasses or the patching glasses that my kid wear? So there's always a question that we get. So it's good that if the visual acuity improves to the equivalent to the good eye, we always kind of stop the treatment. However, you have to actually follow up, because without following up, there could be actually recurrence of amblyopia that can happen. So amblyopic patient, if a patient comes to you with amblyopia, the patient will not say goodbye. The patient will always come for a regular follow-up. Please keep that in mind. If the parent asks you when does the treatment stop, you just say the treatment might stop, but they have to actually come for a regular follow-up at least once in 3 months, especially for kids who are 3 to less than 7 years. Because this is very important because of the critical period. Once we cross the critical period, it's very, very difficult to get back to the same kind of visual functions. Though vision is little bit plastic, there are a lot of adult amblyopia therapies that is coming up, but always doing treatment before the critical period is very, very effective compared to the when they become older. So what did they say? Like from this group of studies, the recurrence was around 25% for kids who were like 1 year after they stopped their treatment. So they waited and saw how many kids like reverted back to getting amblyopia. It was like around 25%. So what they suggested is at least you have to do regular follow-up at least once in 3 months after stopping the treatment. And also when you give patching, say for example, if you gave like 8 hours of patching for a kid, don't abruptly stop the patching from 8 hours to 0 hours. So you have to gradually taper the patching regimen from 8 to 6 and 6 to 4 and then 4 to 2 and then gradually reduce. So if you do that, I think the result that they have got is the recurrence is actually less compared to abruptly stopping the patching, because the fixating eye takes over the amblyopic eye because of the fact that always the fixating eye has got better visual acuity than the amblyopic eye. And for the older kids who are 7 to 12, what they found is only 7% had recurrence amblyopia when they followed them after 1 year. So the take-home message is always early follow-up for kids who are 3 to less than 7 years, and for children who are 7 to 12 years, at least once in a year should be fine. And gradual tapering of patching regimen is better when you follow patching. And it is evident from these studies that the amblyopia recurrence is less common in older children than the younger ones. So it's better to follow them as often as possible. So this is a kind of a flow chart that actually summarizes what I said. So whenever there is a kid who is less than 13-year-old with strabismic or anisometropic amblyopia, give the refractive correction, which is equivalent to their cycloplegic refraction, of course, taking into account the muscle tone, undercorrecting hyperopes, and then give full correction for astigmatism, myopia, and anisometropia when you have the amblyogenic factor. And then for hyperopia, either fully corrected or undercorrected, depending on the refractive error, and also symmetrically reduce the refractive error in both the eyes. And then you have to follow up every 6 to 8 weeks until the amblyopia resolves. And if still amblyopia persists, you go in for patching or atropine or combination of therapies, depending on the improvement in the visual acuity. And when the maximum visual acuity is reached, you have to taper rather than abruptly stopping, and always fix the regular follow-up visit. Because always, if you follow them up, it actually gives them motivation to continue the treatment, and maybe regularly check their vision, because otherwise the parent and the patient will be in trouble in the future because of the difference in the visual acuities. And so far, we have actually discussed about the visual acuity as an outcome, but that is an evident outcome that we primarily see, which is very important. But there are other aspects of visual function, which are also affected, which we can actually kind of check them during our regular workup. So these are the stereo acuity, the amplitude of accommodation, and there is a problem in the contrast sensitivity, which if you can measure. And there are a few other things where even the research is not even conducted, like eye-hand coordination, and a little bit of research is conducted in motion perception. So these are all affected actually, which can actually affect their day-to-day activities. So there may be improvement in the vision, but the eye-hand coordination could be a little bit difficult, and perceiving moving objects could also be difficult. So far I've just described the evidence-based practice, and now there are few other treatments that also exist in the literature, which are these one which I have listed. So there are a lot of treatments like video games or dichoptic training, but there are only few RCTs that they have done, and overall there is no much of evidence to practice. But all these actually gives good amount of improvement, but it has to be added with the conventional treatment. So it should not be primarily given. Rather, you can add these treatments with the conventional treatment. That's what I take these treatments. So, and you have to be very careful when there is strabismic amblyopia, because the fact that because the eye is deviated and they may not really use their strabismic eye, and they may use their fixating eye. So it should be always be under the guidance of an optometrist or ophthalmologist. So these are the things like vision training, video games, and virtual reality programs are also available these days, and perceptual learning therapies. So why do these came up is because of poor compliance with spectacle wear, patching, and atropine penalization, and there is poor or low adherence to those treatment. And also these have more increased engagement. So the kids are very happy to do these games. So we can actually kind of use them, but with caution. And there is also difference in response rate, even if there is a good complaint. So always there is no improvement. It's an additional thing that we can do, as I said before. And there is, of course, there is a recurrence thing that is there in the conventional treatment. And there is also occlusion amblyopia, which is another thing that we missed there. So occlusion amblyopia is so when you cover the good eye and make the amblyopic eye to see, there could also be a chance of occlusion amblyopia in the fixating or the sound eye. So that is called occlusion amblyopia. So these games engage both the eyes together. So there is a chance of decreased occlusion amblyopia. And all these games enhances binocularity, which is not present in patching therapy or even in atropine. But there is a lot of research that is required in this. It is not really kind of more evidence-based, but these exist, and knowing the availability of these will give you good insights for any optometrist or ophthalmologist to know this. So vision therapy, from my experience with the patients that we saw in Shankar Netralia, there are a lot of improvements that I actually personally saw, but these were combined after improvement in the vision, at least 618 to 612. So we train their accommodative functions. We use the red and green goggle to, as an anti-suppression therapy. And these are the various gadgets that we could use to increase their accommodation, increase their vergences, the fusional vergence, the flexibility in using their accommodation and also vergence, and integrate vergence with accommodation so that the binocularity is established after following patching or atropine therapies. There is a software called Amblyopia iNet, which is a software which is like a game that the patient really interested to do that. But this one is monocular; it is not binocular. But there are few kids who are engaged in these kind of treatments also. But there is no proper randomized clinical trial that has been performed to say that these actually work. But this could be additionally used. That's what I repeatedly reinforce. So these are the ways in which we can do all these vision training which are available. So when you advise patching, you can always ask them to do these activities so that it engages more visually rather than normally. So there is another set of binocular dichoptic therapies which actually use either red green goggles or stereo or Polaroid glasses, where they give dissimilar images to each eye. So the good eye receives a low contrast image, and the amblyopic eye actually gets the more contrast image, so that they can try to force to use the amblyopic eye. And also there are activities like where the amblyopic eye will be given more tasks. Say, for example, clicking the colored balls on the figure on the right, like that. So there will be more activity based or more contrast enhanced based kind of games are also available. And there are many VR based games that are actually currently available in the market, but we don't know how far they are good enough to give repeatable results. So there are a lot of randomized clinical trials that are required to establish these kind of softwares. But there are few studies that they have actually did. So I want to quote one study. So they compared the effective iPad game, binocular iPad game versus part-time patching in children between 5 to 12 years. So they did a randomized clinical trial. What they found out that the visual acuity improvement with this particular iPad treatment was not as good as 2 hours of daily patching. So they found that this is not that good, but the 2 hours patching was much better. So as a first line of treatment, we should not be trying to do the gaming or video gaming or action video gaming. Rather, we can wait for a while, just start patching 2 hours and see the improvement in the vision. And during patching, you can give some near vision activities, and then you can add all these things additionally. But so far, there is no evidence-based approach. And so recently, I was searching for a meta-analysis, because meta-analysis give you a good picture of what has been done in the past, so that you don't have to read all the individual articles. So I always are very interested in reading the meta-analysis. So they combined all the binocular treatment for amblyopia, which were like randomized clinical trials. So they took all the studies and analyzed how is the visual acuity, and you can see that the visual acuity. So there is no significant difference in visual acuity between patients treated with binocular and patching. So there is no much difference. So no significant difference in stereo acuity also. So what they concluded is there is no convincing evidence supporting the efficacy of biocular treatment as an alternative to conventional treatment. So it's not like that. That cannot be a conventional treatment. Rather, it can be an additional treatment. That's what has been concluded by this. So it was published in PLOS One. So it should definitely have a very good methodology. So why dichoptic or biocular or binocular treatments are really not more efficient is because it so far whatever has been done is they are not on a homogeneous group of patients. They are all maybe mild amblyopics. They worked on mild amblyopics. We don't know whether it will work in moderate or severe amblyopia. And there are a lot of methodologies, like few needs one eye to close, few needs both the eyes together, and few methodologies like one will give, the picture will be a little bit less contrast to one eye than the other. So the methodology is totally different and we don't know which one to adopt. And also they're all more lab-based research. So the patient will be given extra time and incentives when they do these procedures. And we don't know whether this will work in a day-to-day life. And also it needs a lot of gadgets like iPads, VR systems. So it's a little bit expensive for translate it into a clinical normal day-to-day activity. But there is a lot of good future research that we could, do on these aspects to see whether it really works very well or not. And the next kind of emerging treatment is the brain stimulation. So you can see that there are electrodes that are attached in the head. So basically, this is a very safe and painless procedure. It's non-invasive. We are not going to drill the skull. It's highly non-invasive brain stimulation technique. So they actually trigger or simulate the cortical areas so that the visual functions could be enhanced. So what they actually do is they produce a magnetic field by a plastic coated coil of wire placed on the head. And they give very weak electrical current that stimulates the cortical areas that are for visual function. And they have found that there is a little bit increase in the contrast sensitivity. And actually, so these kind of emerging trends exist, but there are no RCTs that are available. And you can see that this could be done on adults, but not on kids because the kids won't be cooperative. But there is this is also another way to do that. So this was a recent study that was done by Professor Benjamin Thompson. He has been doing these kind of studies in University of Waterloo. So what he did is he did daily 5 sessions of visual cortex simulation, which showed improved contrast sensitivity and visual acuity improvements. But he says that this improvement remained for 28 days of follow-up, but we don't know whether there is no long-standing improvements was seen. So whatever treatment that we give or the time that we spend, it should be long-standing because we can't be doing this for a lifelong. So this is all a bit premature. So we can't really, implement this immediately, but we can, take it as a, future research, whether it works or not at this moment. But there is also a way to simulate the cortical areas. That's what we say. So this is a table that just kind of summarizes the available treatment with the emerging treatment. So occlusion treatment, as we discuss, is a kind of a better speedy improvement. It shows good improvement, but there are disadvantages like low compliance. So the treatment effect is not that good in adults. But when you take the video games, there are a little bit of advantages because the kids are, they like to do them. They are engaging, but it becomes addictive for few kids. So there are advantages and disadvantages. But so far we know that at least first is the optical correction, and then the patching or alternatively atropine could also be used. These have like 100% evidence so far. There are future research if like you are interested in doing a PhD or doing a future research. You can always think about doing all these RCTs in implementing the dichoptic protocols or even the transcranial magnetic simulation. So these are all for the future scope. And I have also seen few articles that shows whether there could be an objective measure of vision rather than the subjective visual acuity. So there were changes that was observed in the VEPs before and after treatment, but very, very few studies have reported. And recently there was also some study that showed structural changes in OCT, but according to the definition of amblyopia, there shouldn't be any structural or structural abnormalities or any ocular diseases. But it has been noted, but we don't know whether it is very much sure because of amblyopia or because of any other reason. So that's why I didn't discuss that much. But there are a lot of many researches coming on amblyopia, especially with respect to the motion perception, attention, and also eye-hand coordination. So there are a lot of scope for the future research. So to summarize this, so what I wanted to say you is, so the treatment for amblyopia, there is very, very good evidence for optical correction, patching, and atropine. And I have discussed all combinations of treatment for all the three. But there are few emerging ones like the vision training, perceptual training, transcranial simulation. Definitely they are improving, but they can't be advised as a conventional treatment. They could be added to the other treatments, but not the primary one, which needs a lot of RCTs. So yeah, thank you very much for inviting me for this wonderful evening. Sorry, for your afternoon. And I thank Tamil Chelvan and Jackma for coordinating this talk today. Sorry for the initial glitch because of some audio problems that I could not reach you. And thank you very much. And if you wanted to reach out to me, please email me. I'm happy to help.
We express sincerest gratitude for your participation as a guest speaker at our event. Your expertise on the topic was evident, and your insights provided a new perspective that generated thought-provoking discussions among our audience. We are very much grateful to you for considering our request and joining us online in such short duration of time. Once again, a heartfelt thanks to you, ma'am.
Thank you very much.